that will segue us into our roundtable discussion, which Dr. Gandhi and I will moderate, but many of our panelists from earlier in our symposium will contribute to our roundtable discussion. And we will start with some of the questions that are left over from the Q&As and direct those to the appropriate speaker. And anything that didn't get addressed during our Q&A will hopefully get addressed during our roundtable discussion. So if we could move some of those questions over for our panelists to be able to recognize. Maybe I'll turn this over to you, Raj, if you would like to get started with the discussion, and we can kind of alternate how we deal with the question.
Happy to. So let's go back to the morning session where we heard about the emergence of variants and the fact that immunosuppressed individuals have viral persistence. And so I'll direct this question to Dr. Bender-Ignacio. And it's this attendees from the morning asking if you could expand upon your comment about Omicron variants and immunosuppressed individuals in Africa. Any more light you can shed on that? And maybe also harken back to your comments about equity and trying to get people vaccine.
Yeah, absolutely. So we have evidence from a number of case series, a number of examples of extremely immunosuppressed patients who continue to shed viable SARS-CoV-2 for long periods of time, for months, in some cases more than 6 months. And while we don't know that Omicron arose specifically in a person with HIV, or actually which type of immunosuppression, the supposition is that when you look at the lineage on a phylogenetic tree, when you look at how Omicron arose, it sort of is a straight line back to the ancestral or alpha, closer to those two versions than what was circulating at the time that it arose. And because it has so much similarity to what was circulating almost a year before that, it seems as though this was one, long persistent infection, probably in one or a few individuals for a very long time. And so again, we can't say that this was specifically in an individual who's immunocompromised because we don't know the first person who had the BA.1 variant. But what we know is that if you just look sort of epidemiologically at where in the globe people are immunocompromised and who's at risk for being the type of person who could have, very persistent replication of SARS-CoV-2 in their body, and looking at all forms of immunosuppression from cancer treatment to autoimmune disease being treated to HIV to transplant, the largest condition would be HIV, and the largest concentration of those individuals would be in the southern cone of Africa. So from a public health standpoint, it makes a lot of good sense. I mean, as well as obviously the equity argument, which should be at the forefront of all of our decision making, to focus on both individual health reasons for vaccination and also to sort of prevent the development of variants by making sure that both vaccines and treatments are equitably distributed, especially to places that have a high proportion of immunocompromised people.
Can I just make one comment?
Please go ahead, and then I'll just add one more comment. You first, John.
Thanks, Raj. So I totally agree with Dr. Bender-Ignacio. I would also say that variants can arise really all over the world, right? As we've already seen, Alpha from the UK and Gamma from South America, Delta from Asia, and there are likely there are immunosuppressed patients all over the world, and at this point it does seem like these variants can occur and arise in multiple, pretty much globally, anywhere in the globe, and actually and I think that we are not, quote unquote, kind of immune to this ourselves. I mean, you remember we had the California variant and then the New York variant, right? I think we just got lucky that those variants got edged out by some of these other ones that have come along. But I do think that really there's no place in the world that is necessarily safe as long as there is high levels of community spread and infection.
So I have a question for Dr. Haydar. Given your experience with prolonged viral shedding in immunocompromised patients, what do you do or recommend for infection control?
Yeah, that's a fantastic question. And I actually helped devise some of the infection control guidance. A lot of it is stuff we sort of learned as we began to understand that some of these immunodeficient individuals can sometimes harbor infectious virus that you can, let's say, isolate in a lab, or if you can't isolate it in the lab, on serial sampling, you're documenting that the genome is evolving. And so clearly there's something that's actively replicating there. And so as soon as we began to understand this, I reached out to our infection prevention colleagues and highlighted the problem to them. It was around that period of time when we were writing about this. Dr. Lee's group had just published about this, and it was before the CDC had sort of devised any of their own guidelines. And so we now have these specific tiers that are really dependent on the degree of immunosuppression, where if you're a normal host, we just go by 10 days-ish. If you're sort of mildly immunocompromised, an example there would be a remote kidney transplant, for example, we stop isolation at 20 days. What the conditions that we are defining as moderate to severe, these are the ones that we refer to as isolation forever / until you document 2 negative SARS-CoV-2 PCRs. It's not perfect. And we had a lot of discussions about how to streamline this. Do we use antigen testing? It's not available readily in the hospital, so we opted not to. Do we use cycle-threshold testing? There wasn't really good appetite from the hospital system as a whole to do that. Do you lump it in with symptoms? But then there's case reports of people with minimal symptoms having protracted infection. Do you add antibody testing with it, thinking that if someone has an antibody response, maybe this RNA that you're detecting is just inert, non-replicating virus? We opted not to because it's not that simple. And we've seen people who have detectable antibody levels with protracted SARS-CoV-2 infection, and then they develop resistance to the monoclonals. And then we think, well, maybe the antibody we're detecting is the monoclonal, not their endogenous spike. So it's really complex. At this stage, it's sort of accepted at our institution that this is sort of what's done for the very, very immunocompromised people. So let's say a new lung transplant, CAR-T, fresh BMT, advanced HIV with a really low T-cell count. They remain in isolation until you have these negative swabs. And it becomes a problem not just for inpatient policies, where people can be a bit frustrated from these very long hospital stays, but also to give patients advice when they leave and when they go home and they want to get on with their lives. That's also something that is difficult. And I try to explain all this to them. And in my experience, most have sort of listened to me. I think they're just so, I want to say, traumatized by their experience dealing with COVID, and they don't really want to give that to anyone else. So I tell them, get on with your life, but also try to do it as safely as you can. If you have to go out, wear a mask and, all that stuff.
Great. Raj, I'll throw it back to you.
Let's go back to variants for a minute and also talk a little bit about monoclonal antibodies. We heard earlier today that the BA4 and BA5 should be susceptible to tixagevimab, cilgavimab, at least based on laboratory studies. Obviously, tixagevimab, cilgavimab, also known as Evusheld, is being used for prevention. I want to ask a question about whether this should be considered for treatment. Maybe Dr. Lee, you want to comment on, is there a role for that particular antibody cocktail for treatment? It's not authorized, so it can't be done today, but should it be authorized for treatment?
Yeah, it's an interesting question. And I think Roger referring to the recent only published ACTIV-3 trial, which looks at tixagevimab, cilgavimab, or Evusheld for inpatient treatment. And this is, the latest of a long line of studies looking at antivirals for inpatient management, almost all of which have come back I would say, negative at this point, especially with the monoclonals. They've looked at bamlanivimab, looked at casomdevimab, looked at it. Now, I will say that there are subpopulations and sub-analyses that have shown some signals. For example, in the recovery study, individuals who are seronegative appeared to do better in terms of mortality with casomdevimab. And in this particular trial with tixagevimab, the initial kind of primary outcome, which is time to sustained recovery, there was no significant difference, right? So the primary endpoint failed here, but they did find that mortality rates were lower in individuals, hospitalized individuals who were treated with tixagevimab. Now, I think that right now I think our hands are tied because this is not a FDA approved drug. It's just FDA authorized and only authorized in certain populations for pre-exposure prophylaxis and such. And so we can't actually use it in the hospital. But I think that the data on mortality here is interesting. And I think that it does warrant additional kind of study. And I'm sure the FDA is taking a close look at this data to see whether it should be authorized. I will also say that all of these inpatient studies, not clear how well they are actually extrapolatable to the immunosuppressed population. They really, in general, enrolled very few immunosuppressed individuals. And I do think that, for the immunosuppressed patient who has chronic COVID, when available, I'm a fan of monoclonal antibodies for hospitalized patients. I see Gadi there nodding his head as well. I think that I don't know that when sotrovimab was available, that drug was available for compassionate use, but right now we have a hard time getting it for inpatients, and we don't really also have access to convalescent plasma as well, even though that is authorized for immunosuppressed patients. So our hands are tied. But the ACTIV-3 trial, I think, did show some interesting signal with mortality and in hospitalized patients. And I think the FDA still waiting on more FDA guidance.
But John, I would just add, ACTIV-3, that study enrolled last year with earlier variants. Is that right? And so we do have to think about the activity of the Evusheld, very sorry, for the variants that are circulating now, and in the future there is there are somewhat large fold change reductions in susceptibility with the newer variants, maybe less so with BA.2.75 now, actually. And I think there's a real balance there in terms of thinking about the drug concentrations that we're going to get and the expected clinical activity for current variants.
So Dr. Chu, since you brought up BA.2.75, and because it's been found in California, I want one of you to comment. So can you just tell the audience what is BA.2.75? How concerned are you? And what do we know about how it might respond to different treatments? So just fill us all in.
So, not being a virologist, it's, as far as I understand, a sublineage of BA.2. It does so it is a variant where bebtelovimab, actually, I think for the first time for all the variants that we've seen so far, where there does seem to be some reduction in susceptibility, but maybe not to a degree that would actually impact clinical activity of bebtelovimab. And it's a variant where perhaps some of the other monoclonals that have not been in use may actually have gained activity again. And so I think it's unclear at this point how much it will kind of take over as the dominant variant in the population. But so far, at least, I think that the therapeutics that we have would likely remain active.
Yeah, it seems like BA.2.75 is predominantly right now in India and some other countries in Southeast Asia, where there isn't a lot of BA.5 so far. So it's not clear yet whether it's going to be an alpha-P BA.5. So the jury is still out, as Dr. Chu stated.
So let's go back to the HIV population for a couple of questions, and anybody can chime in, but I'll maybe direct the questions to Dr. Bender, if she's still on, Bender Ignacio, but maybe Teresa also. Is there evidence of greater immunologic morbidity in people with advanced HIV? One might expect there could be some protection against some of the immunologically related post-COVID syndromes balanced against the risk of other virologic driven injury because they're not able to, because people with advanced HIV don't have such robust immune responses to other things. I hope I'm paraphrasing the questioner's question appropriately, but I think what we're trying to get at is people with advanced immunosuppression don't have robust inflammatory immune responses to other things. We might see an amelioration of some of the immunologic comorbidities associated with COVID?
I unfortunately don't think so. I mean, I think this was a hypothesis early in the pandemic that it might not be, that we might not see the severity, but because we see a trend towards increasing severity as the CD4 count goes down, it's hard to say that we would see less severity among the most immunosuppressed folks. Those are exactly the folks that we're seeing in the ICU or had been seeing in the ICU earlier on. And as well as people that have, for example, a low CD4 count plus advanced age. So it seems to be that being immunologically vulnerable increases vulnerability for both severe COVID outcomes, and then from the small amount of data that we have about post-acute COVID, that potentially, again, people with sort of more immune exhausted phenotypes or lower CD4 count might be at higher risk of long COVID sequela as well.
And Dr. Evering, is that your thought as well for people with HIV and long COVID?
Yeah, I absolutely agree with everything that Dr. Bender-Ignacio said, and also will point out that there are many potential mechanisms that could lead to long COVID, and over stimulated or immune activation is just one. But everything that she said, I would agree with.
Great. Are there any new data? This could be directed to almost anyone on the risk of herpes zoster activation following vaccination for COVID-19. Anyone had experience with that? Not hearing a lot of positive responses there, so. Okay, Raj, you want to field another question?
I wanted to put a question to Dr. Janong around TPOXX. You described some of the considerations that go into making a decision as to whether to prescribe it. It's very, very onerous to prescribe because of the way it's being handled through an IND. This is really just asking for your perspective. Is there enough evidence for TPOXX that it really should be made available through expanded access or some other less onerous mechanism, or does it still need to be studied? What's your perspective on that drug?
My feeling is that it still needs to be studied. The history is really that it was, there's good animal data in lots of other animal populations in terms of viral decline, in terms of clinical improvement, but not a lot of human data because it really arose as a treatment for smallpox, and because there wasn't smallpox around. The FDA made the leap of faith from animal studies to give FDA approval for smallpox, given the threat. But now in monkeypox, we have, thousands of cases all around the world now. It presents a golden opportunity to look at it. We can take one of two pathways or three. One is you continue to treat the most severely ill people with a very low threshold to give it to them. Compassionate use. The second would be to then look at the people with intermediate illness and below, and then study that in a randomized fashion. And then three would be basically to just give it to everyone. But I think most people, if you're going to invest in this drug, and because this may become endemic, this is the time to really look at that. So not a lot of great data in humans at all.
Would you feel comfortable referring your own patients to a randomized trial? And do you think your patients would accept it, or would they seek out some other way of getting it?
I think the patients who we would not normally treat would probably be fine with a randomized control trial. There's some ethical issues. I mean, there is not a lot of countries that have access to this drug. So the other issue would be whether or not you could ethically do a randomized control trial, given the paucity of human data, make it a global trial in which, people would participate. I would say right now, because there's so much severe disease treatment with TPOXX, it would be very, very difficult to randomize folks in that severe illness category who've been hospitalized, for example.
But perhaps a milder patient population, not near the eye, not in someone who's immunosuppressed, for example. Great.
So we have a question. I know we had a lot of discussion earlier about rebound, and I think we addressed the primary question that rebound does not just occur with Paxlovid treatment, but how much have you seen COVID rebound with people who've recovered just after a mild to moderate untreated COVID syndrome? Have you seen people who've just gotten symptomatic care with rebound following recovery? What's people's experience with that?
Well, I think that in the trials, it was interesting of Paxlovid in the placebo group, 1 to 2% of people without Paxlovid, when you check them, had rebound. And I think we're not checking a lot of people, so they probably is more than meets the eye, but certainly I've had isolated cases of people who were hospitalized for a very long period, like the case I presented, where they had recurrent symptoms, and maybe it wasn't due to just the effects of SARS-CoV-2, but the rebound, the virus was found. So they were typically immune compromised individuals and a few patients that I've seen, but the vast majority, I haven't really seen clinical significant rebound.
And again, I think we touched a little bit on this topic, but maybe just expand a little bit more on the use of home antigen testing during, or yes, I guess during rebound, with or without symptoms. Most of the cases that have been reported and the experience that's been reported, home antigen tests turn positive again after turning negative during Paxlovid rebounds. But if the home antigen test remains positive, what is your recommendation for isolation and quarantine? We heard about the inpatient setting. What about in the outpatient setting?
I can start that again and have others chime in, but essentially the CDC says restart the clock, which I think is really interesting because, together with the data of the maybe lack of efficacy in the general population that's not high risk and certainly vaccinated, et cetera, boosted versus the unvaccinated or high risk and vaccinated, with minimal effect or just a slight, not statistically significant anyway. When you talk to a person who would have normally wanted Paxlovid, who's in the general population, whether or not they would have seek it sorted out otherwise, they're afraid of getting rebound because it will just be more imprisonment. So that's kind of like a discussion in the community right now, because a lot of people prior to this was everybody is trying to get Paxlovid regardless of age or risk, et cetera. So I think the risk benefit changes now, given that specter.
I wonder if Dr. Lee might comment, because the study that Dr. Kim showed earlier, where 7 people studied who had rebound, 3 of the 7 had positive cultures. Some of those cultures stayed positive for a really long time, even more than 10 days. And
Right.
you know that those people are definitely infectious, or do we just surmise? I agree with Chin Hong, though. This is really tempering enthusiasm for Paxlovid, and I think maybe we should not go too far in the other extreme. If someone is older, frail, has risk factors, I think we should put this rebound in context. But do you want to comment, Dr. Lee, about antigen or culture positivity and infectivity?
Well, so that study we performed with a number of collaborators here at MGH and Brigham, and including Amy Barzak, who's the head of the Reagan Institute Biosafety level 3 facility who did all the culture work. And in our hands, I would say that I was, generally the viral loads that lead to or are associated with culture positivity is right around 5 logs. And that's also generally when the antigens start turning, either positive or negative, depending on which direction you're going. And so we do think that these individuals are shedding culture positive and infectious virus. Now, whether they're any more or less infections than during acute infection, we can't say for sure. But I do think it makes sense that when they do have viral rebound symptoms with positive antigen and relapse in symptoms, that they re-isolate. To me, that makes a lot of sense. And then when my patients kind of ask about this issue, I say, well, in the end, the EPIC HR study showed that this drug had a 90% efficacy in terms of hospitalization and death. And really, in the end, that's what we care about. Most of the relapse cases that I've heard about are relatively mild, and self-limited, and no one I know of has been hospitalized with it. And so it is a bit of a nuisance. But in the end, for those who are really high risk, I say, don't worry about the rebound. I mean, obviously, be aware of it. But really the goal is to prevent you from being hospitalized and to have severe illness.
I have to think about the way that we evaluate data in the clinical trials. When we look at sort of duration of symptoms or things like that, I wonder if maybe, I can't say this specifically about the EPIC SR data, but, is it that what the people that are not the high risk people that we're hearing either anecdotally or through, data collection that are having rebound, for example, might have converted their positive test and lost most of their symptoms, let's say 3 days earlier on average than someone who didn't take Paxlovid and then rebounded. And so, maybe on average, they're still having sort of the same degree of test positivity and symptoms overall. Like if you had checked after 8 days, they just declined faster and came back. And so I'm wondering if you sort of look at the overall kind of area under the curve, you just can't detect a difference. It's a different cadence. So I think I'm trying to use that to convince people that, again, that's just a hypothesis because we don't have those specifics, but that it's not a danger, that it's not something that we're putting somebody at risk through this rebound. It's just overall, it's probably a wash in some people who were not high risk to begin with. But as Dr. Lee said, for the people who were really using this to prevent severe outcomes, it's still doing that for them.
Last question I can take us back to HIV just for a minute and delve into vaccination in people with HIV. We heard this morning that the CDC recommends a second booster for the general population in those over the age of 50. But we also heard some data that people with HIV who have a CD4 count less than 350 do have a high rate of breakthrough infection and probably serious disease. Should we be vaccinating our HIV positive individual, our patients with HIV who are under the age of 50 with a second booster if their CD4 count is less than 350? What would anyone of you advise a patient whose CD4 counts less than 350? Connie, you're either shrugging your shoulders or giving us the answer.
I recommend that they get boosted regardless of age if they have a lower CD4 count. So I don't follow the greater than 50 age cutoff for my population with HIV. Anyone else have comments?
I completely agree with you. I mean, there's also other factors, even independent of CD4 count, the syndemic of vulnerable population that makes that age, cut off somewhat arbitrary when you think about it. So, I agree with you, Connie. I would have a low threshold for recommending that particularly for somebody with low T cells.
And they also have the multiple comorbidity issues, the social determinants of health issues are all overrepresented in our HIV population. So I think there's multiple reasons to recommend boosting in those individuals, regardless of age.
Great. Well, you heard it here first, but I think that's a very cogent recommendation.
Okay, there's a question for, I guess, Dr. Evering. Would you treat the depression as a sign of long COVID with SSRIs, or regardless of whether they had pre-existing depression prior to COVID, would you treat that depression? You're muted, so could maybe unmute your microphone.
Yeah,
There.
sorry about that. There are tools and a diagnostic pathway using the DSM to diagnose depression. And so, yes, irrespective of how we think they may have come to this point, if we're diagnosing depression, that would be improved with treatment. I think that if an SSRI is in the pathway, that would be a reasonable approach. But again, I think that when we're focusing on the symptom-based approach to care, we have to make sure that we have the right definitions for what we're treating. But I think that sounds very reasonable in the appropriate patient.
Well, we are 10 seconds away from our end time, so I think we will stop with our Q&A and discussion and move on to closing.